welcome back to the Deep Dive. Our goal today is to take a stack of dense pharmacological sources and really extract the foundational knowledge required for true mastery.
Absolutely.
We are journeying into, well, probably the most prescribed and often misunderstood class of drugs, those that manage the chemical architecture of mood and anxiety.
Yeah, the pharmacology of affective disorders.
Exactly.
This is such a vital area, and you're right, the sources are precise. We really need to move past simply naming drug classes. We need to understand the mechanism, what's actually driving the clinical choices, and just as importantly, the toxicity.
Right.
So our mission for you, the listener, is to really get a handle on the working classification, understand the why behind the side effects, the uses for every major agent we talk about today.
Okay, let's unpack the starting point then. Defining the affective landscape itself. What are we actually talking about here?
We're dealing with pathological changes in the mood state. Think of it like a spectrum.
A spectrum.
Yeah, with, say, major depression and mania as the two clinical extremes.
And for major depression, it's crucial to understand the symptoms go far beyond just feeling sad, right?
Oh, absolutely. While a sad mood is usually there, the really critical diagnostic feature is anhedonia.
Anhedonia.
Yeah.
That's the loss of interest or pleasure.
A profound, pervasive loss of interest or pleasure in nearly all usual activities. And when that happens, it's almost always coupled with significant vegetative and cognitive symptoms.
Like what specifically?
Things like sustained low energy, crippling feelings of worthlessness or guilt, and often really dramatic physical changes.
Those physical changes, they're key indicators, aren't they?
Yeah.
Of how severe the underlying pathology might be.
Definitely. We're talking about observable psychomotor changes.
So that could be moving really slowly.
Right. Extreme slowness, reduced movement. That's called retardation.
Right.
Or sometimes the opposite agitation, restlessness.
Okay.
Plus, you almost always see severe disturbances in appetite and sleep. And in the worst cases, this can culminate in, well, presentations of melancholia or even active suicidal thoughts.
It's also crucial, I imagine, to distinguish the types of depression. It's not all the same.
Not at all. We need to distinguish between unipolar depression, just the depressive episodes, and the more complex bipolar cyclic disorder.
That's where you see the mood swings.
Exactly. Dramatic pathological mood swings, cycling between those depressive phases, and then periods of mania or maybe hypomania.
And we can't forget the connection between mood and anxiety. They often seem to go hand in hand.
They absolutely do. They exist on a spectrum. People talk about the anxiety-depression axis.
Makes sense.
Pathological anxiety, if it's left unchecked, very frequently precipitates a depressive episode. And if you look at the global health data, well, the sources confirm anxiety and depression together are the leading psychiatric disorders today.
Which means the demand for effective treatments is just immense.
It really is. And that sets the stage perfectly for the drugs designed to intervene, the antidepressants.
Okay, so definitionally.
Simply put, there are compounds designed to elevate mood in depressive illness. But what makes this whole area hang together pharmacologically, what ties almost all of them together, is one universal principle.
Which is?
Virtually every single drug that proves effective as a true antidepressant, from the very first ones back in the 1950s right up to the newest atypical drugs, affects monoaminergic transmission in the brain in some significant way.
Monoaminergic. So we're talking noradrenaline, serotonin, dopamine.
Exactly. Noradrenaline or NA, serotonin, 5-HT, and sometimes dopamine DA. They modulate the levels or the actions of these key neurotransmitters.
But here's where it gets tricky, right? Over the decades, we've developed so many compounds.
Hundreds, yeah.
And they hit different targets, different reuptake pumps, different receptors, different enzymes.
Precisely. It makes establishing a clear, clean classification really challenging. You have to move beyond just the chemical names and really understand the targets.
Because they don't just affect the intended target, the amine transporters.
That's the crux of it. The complexity arises because these agents have such diverse effects, not just on the biogenic amine transporters, but also on various pre- and post-junctional receptors. And that's where many of the, frankly, debilitating side effects come from.
So mastering this classification is what separates basic knowledge from really understanding the therapeutics professionally.
Couldn't have said it better myself.
Okay, so let's start at the absolute foundation then. Section 1. The monoamine oxidase inhibitors, or MAOIs. This takes us right into fundamental enzyme function.
Right, we're talking about monoamine oxidase, or MAO. Think of it this way. If monoamines are the messengers, MAO is kind of like the janitor.
Their janitor, okay.
It's a mitochondrial enzyme, and its job is the oxidative deamination of biogenic amines. Basically, it breaks down and inactivates adrenaline, noradrenaline, dopamine, and serotonin after they've done their job. It makes sure the signal gets turned off.
And crucially, this janitor comes in two different versions, which sounds important for clinical safety.
Very important. We have two major isoenzymes, MAO and MAO-B.
And they handle different things.
MAO-A preferentially handles serotonin, 5-HT, and noradrenaline, NA. You find it mostly in peripheral adrenergic nerve endings and, importantly, in the gut mucosa and placenta.
Okay. And MAO-B.
MAO-B preferentially degrades something called phenylethylamine. It's predominant in certain brain areas, particularly serotonergic ones, and also in platelets.
What about dopamine?
Dopamine's the odd one out. It gets degraded pretty equally by both MAO-A and MAO-B. And the liver, well, it contains both isoenzymes.
This distinction seems immediately relevant when we look back at the first-generation MAOIs. The history there is interesting. Serendipity and serious problems.
Oh, definitely. Improniazid, discovered back in 1951, wasn't even meant for mood disorders.
Right, it was for TB.
Exactly. It was a hydrazine compound used to treat tuberculosis. But clinicians noticed that patients became, well, disproportionately cheerful, energized.
And they connected that to the drug's effect on amines.
They quickly connected this mood elevation to its property of inhibiting the degradation of biogenic amines. This discovery led directly to drugs like phenelzine and isocarboxazid, which are hydrazine-related, and tranylcypromide, which is actually related to amphetamine.
But these first-generation MAOIs quickly ran into trouble because of their severe toxicity.
Yeah.
What was the core pharmacological issue?
Two big things. First, they were non-selective. They hit both MAO-A and MAO-B. But far worse, they inhibited the enzyme irreversibly.
Irreversibly?
Meaning the enzyme molecule is permanently disabled. The body has to synthesize entirely new enzyme molecules to replace them, and that can take weeks.
Wow.
This created an immense and frankly dangerous risk of drug and food interactions, which ultimately led to their relative unpopularity. They're generally reserved for specific cases today.
Let's dive into that toxicity, because this historical point is still a critical safety briefing today for anyone encountering these drugs. Beyond common things like postural hypotension or insomnia.
Yeah, those happen. Restlessness, sexual dysfunction to impotence, loss of libido. But the big one, the classic one, is the infamous cheese reaction.
The cheese reaction. To explain that pharmacodynamically.
Okay, so certain aged or fermented foods, strong cheeses, cured meats, certain red wines, beer, yeast extracts like Marmite, they contain naturally occurring compounds called indirectly acting sympathomimetic amines. The main culprit is tyramine.
Tyramine. And normally, our body deals with this.
Normally, yes. MAO-A, especially the enzyme right there in the gut lining and the liver, quickly detoxifies or deaminates this tyramine before it can get into the main bloodstream.
But if that MAO is irreversibly shut down by one of these old drugs,
then the tyramine basically bypasses that first line of defense. It escapes into the systemic circulation completely intact.
And once it's in the bloodstream?
Once it's there, it acts as a potent displacing agent. It goes to the sympathetic nerve endings and forces the release of massive, uncontrolled amounts of noradrenaline.
A flood of noradrenaline.
An instantaneous flood. And that causes a severe, potentially life-threatening hypertensive crisis. Blood pressure skyrockets. This can rapidly progress to intracranial hemorrhage, stroke. It's incredibly dangerous.
Which explains the need for strict, lifelong dietary vigilance for patients on those older, irreversible MAOIs.
Absolutely essential. No shortcuts.
And this danger isn't just limited to food, right? You see similar problems with other substances.
Correct. Similar catastrophic reactions can happen with common over-the-counter cold remedies that contain sympathomimetics like ephedrine or pseudoephedrine, and critically, with other drugs that affect monoamines like TCAs, SSRIs, SNRIs, even levodopa used for Parkinson's. Combining these is generally contraindicated.
You also mentioned potentiating CNS depressants.
Yes, things like alcohol, barbiturates, opioids, their effects can be dangerously amplified.
And there's a specific highly toxic interaction with pethidine, the opioid.
Yes, this one is unique and extremely dangerous. MAOIs actually slow down the breakdown, the hydrolysis of pethidine. This leads to an accumulation of an excitatory metabolite called nopethidine.
Excitatory, not depressive.
Right, and this buildup causes a very distinct syndrome. High fever, sweating, delirium, muscle rigidity, convulsions, and paradoxically severe respiratory depression. It's a bizarre and dangerous mix. You simply cannot combine MAOIs and pethidine, period.
Thankfully, pharmaceutical science didn't stop there. They developed a modern, much safer MAOI alternative.
Yes, the reversible inhibitors of MAO-A, or RIMAs. Moclobamide is the key example here.
Moclobamide, what makes it safer?
Two key things. First, it's selective, primarily inhibiting MAO-A. Second, and this is crucial, the inhibition is reversible.
Reversible, so it doesn't permanently disable the enzyme.
Exactly. Its duration of action is much shorter. If you stop the drug, MAO activity recovers pretty quickly, usually within just 1 to 2 days, not weeks.
And how does that reversibility protect against the tyramine threat, the cheese reaction?
Because the inhibition is competitive. If a patient on moclobamide happens to ingest some tyramine, the higher concentration of tyramine can actually physically displace the moclobamide molecule from the enzyme's active site.
Ah, so the tyramine essentially kicks the drug off.
In a way, yes. It allows the tyramine to then be metabolized and degraded naturally by the now-free enzyme. This means the risk of that dangerous pressor potentiation, the hypertensive crisis, is significantly reduced.
So dietary restrictions aren't as strict.
While caution is always wise, the really strict, life-threatening dietary restrictions needed for the irreversible MAOIs are generally not required with moclobamide. This profile makes it effective in mild to moderate depression, much safer for elderly patients or those with heart issues, and it's also found use in managing conditions like social phobia. It lacks those severe anticholinergic and cardiovascular side effects of the older classes.
The lesson here seems crystal clear. The history of MAOIs really teaches us that non-selectivity and especially irreversibility are major liabilities.
Right.
Liabilities that clinical pharmacology has aggressively worked to solve.
Precisely.
But because those early MAOIs were so dangerous, the field desperately needed alternatives. Drugs that could work, but without that catastrophic toxicity.
And that pivot leads us directly into Section 2, the first-generation powerhouses, the Tricyclic Antidepressants, or TCAs. These were the dominant class for decades.
Their origin story is interesting, too, tied to early antipsychotics, wasn't it?
It was. Imipramine, which is structurally an analog of the antipsychotic chlorpromazine, was the first compound found to selectively benefit depressed patients. The key discovery was its ability to inhibit the reuptake of both noradrenaline and serotonin.
But they definitely earned the nickname dirty drugs for a reason. What defined this first-generation action pharmacologically?
It wasn't just the inhibition of the norepinephrine transporter and the serotonin transporter, SERT, that was the therapeutic part. The dirty part, the reason for the side effects, was their simultaneous off-target interaction with multiple other receptors.
Which ones?
Specifically, muscarinic cholinergic receptors, alpha-1 adrenergic receptors, and histaminergic H1 receptors. This multi-receptor blockade is the absolute root cause of both their, broad therapeutic applications sometimes, but also their immense side effect burden.
It's interesting. If a non-depressed person takes a TCA, they don't feel good, right? They feel clumsy, tired, maybe lightheaded.
That's typically reported, yes. Unpleasant effects, maybe even some anxiety. Not euphoric at all.
So how do we explain the therapeutic effect in actually depressed patients? And crucially, what's the timeline for that?
Well, aside from an immediate sedative effect from the H1 blockade, there's virtually no acute effect on the core mood symptoms. The mood elevation, the actual antidepressant effect, is profoundly gradual.
How gradual?
You need continuous treatment for at least 2 to 3 weeks, sometimes longer, before significant improvement is noted. TCAs work by gradually reducing the core depressive symptoms, the deep sadness, the anhedonia, the lack of energy. They don't provide a temporary high or quick fix.
And we also need to remember the seizure risk.
Yes, that's an important point. TCAs are known to lower the seizure threshold. Some, like climipramine and maybe bupropion, which we'll discuss later, seem to have a higher potential for this than others.
Okay, this brings us to probably the most intellectually fascinating question in this whole field, the time delay. We have the monoaminergic hypothesis, right? Depression caused by deficient NA or 5-HT transmission.
That's the classic hypothesis, yes.
And it's supported because drugs that deplete these amines, like reserpine, can sometimes cause depression, and all the effective antidepressants seem to enhance synaptic availability of these amines.
Correct.
But here's the discrepancy. If I take a TCA or an SSRI, it blocks that reuptake pump almost immediately. The levels of NA and 5-HT in the synapse go up right away. So why does the patient not feel better for weeks?
This is the absolute crux of mastering this field. It forces us to move way beyond the simplistic chemical imbalance theory that you often hear.
So what's happening in those weeks?
Okay, think about it. That immediate massive surge of NA and 5-HT that occurs when you block the reuptake pumps, it triggers a compensatory reaction in the brain, a feedback loop.
The brain tries to counteract the drug.
Exactly. It activates specific presynaptic autoreceptors. These are like sensors on the neuron that release the transmitter. For NA, it's the inhibitory alpha-2 autoreceptor. For 5-HT, it's the inhibitory 5-HT1A and 1D autoreceptor.
Inhibitory, so they slow things down.
Precisely. These autoreceptors act like internal neuronal speed limits. They immediately detect the suddenly high transmitter levels in the synapse, and in response, they signal the neuron to decrease its firing rate, to release less transmitter.
So the initial effect of the drug is kind of self-defeating or blunted.
You got it. The brain hits the brakes. The 2 to 3 weeks or more of continuous dosing are required to gradually wear down or desensitize these inhibitory autoreceptors to make them less sensitive to the high transmitter level.
Once those brakes are less sensitive.
Once you remove that neurological brake, it allows for sustained, enhanced neurotransmission. This then induces subsequent adaptive changes, downstream changes in the sensitivity, and even the number of postsynaptic receptors, changes in gene expression. It's a cascade. And that finally culminates in the clinical antidepressant effect we're aiming for weeks later.
That structural delay, that need for adaptation, it leads us right into the neurotrophic hypothesis, doesn't it? If uptake block is instant, the effect takes weeks, and we know depression can involve structural changes in the brain, like reduced hippocampal volume, are we actually treating more than just a chemical deficiency?
That is a highly accurate and modern way to frame it. The neurotrophic hypothesis provides a compelling complementary explanation for the time lag.
Explain that hypothesis.
It links depression not just to neurotransmitter levels, but to a potential deficiency of key growth factors in the brain, particularly brain-derived neurotrophic factor, or BDNF.
BDNF, what does that do?
And BDNF is absolutely essential for neuronal health, for survival, for strengthening connections between neurons, that synaptic plasticity, and even for the growth of entirely new neurons, neurogenesis. This happens particularly in areas crucial for mood regulation, like the hippocampus and other parts of the limbic system.
And depressed patients might have less BDNF.
Studies often show reduced BDNF levels or activity in depressed individuals, and stress, a major trigger for depression, is known to decrease BDNF. Conversely, successful antidepressant treatment, regardless of the drug class, seems to increase BDNF levels over time.
So the two hypotheses in the monoamine changes and the neurotrophic changes, they're linked by that critical factor, time.
Precisely. The final unifying synthesis, the current thinking, is that the prolonged monoaminergic enhancement achieved by the chronic use of the antidepressant, those weeks it takes to overcome the autoreceptor braking system, indirectly promotes the production and release of BDNF and perhaps other nerve growth factors.
And that BDNF then drives the therapeutic changes.
It drives the necessary neurogenesis, the synaptic remodeling, the structural repair in those key brain circuits. The therapeutic delay isn't a failure of the drug. It's the necessary time required for the brain to undergo this adaptive biological remodeling. It's literally rewiring itself, albeit slowly.
That completely transforms how you think about treatment. It's not just topping up chemicals, it's facilitating brain repair.
Exactly. A much more dynamic process.
Okay, that context is crucial. Now let's move to the practical and often problematic side of TCAs, their pharmacokinetics and especially their side effects. How are they handled by the body?
Generally, TCAs are well absorbed when taken orally. They bind very strongly to proteins in the plasma and tissues, and they have a large volume of distribution, meaning they spread out widely in the body. They're metabolized extensively, primarily in the liver.
And that metabolism can be complex.
Yes, a key detail is that many TCAs, imipramine is the classic example, are metabolized into active metabolites. Imipramine gets demethylated to dicipramine. And sometimes these metabolites have slightly different pharmacological profiles. Diapramine, for instance, is relatively more selective for inhibiting noradrenaline reuptake compared to serotonin reuptake.
And they stick around for a while.
They tend to have long plasma half-lives, often in the range of 16 to 24 hours, sometimes even longer. This conveniently allows for once-daily dosing, usually at bedtime because of the sedation.
But there's this issue of a therapeutic window that complicates dosing immensely.
Yes, this is an unusual and important observation flagged in the sources. For many TCAs, the optimal therapeutic effect seems to occur only within a relatively narrow band of plasma concentrations.
So too low doesn't work, but too high also doesn't work as well, or becomes
Yeah.
toxic.
Exactly. For ibuprofen, for example, that window might be something like 50 to 200 nanograms per milliliter. Below that, you might not get efficacy. Above that, efficacy might actually decrease, and toxicity certainly increases.
And given that people metabolize drugs differently.
Precisely. There's huge individual variability in how quickly people metabolize these drugs due to genetic factors influencing liver enzymes or interactions with other medications. This narrow therapeutic window, combined with the variability, makes careful therapeutic drug monitoring, actually measuring the plasma levels, and meticulous dose titration absolutely essential for safe and effective use of TCAs, much more so than with newer agents.
Let's talk about the price of that dirty multi-receptor action we mentioned earlier. The adverse effects that really drove TCAs out of first-line use for most patients. The autonomic nervous system effects are bothersome, but the cardiovascular effects, those are the deadly ones.
Right. The high-potency blockade of muscarinic cholinergic receptors causes significant anticholinergic side effects. We're talking a really profound dry mouth, severe constipation, blurred vision due to effects on accommodation, difficulty urinating, cognitive slowing, or confusion, especially in the elderly. Urinary retention is a particular danger for older men who might have an enlarged prostate.
Annoying, but usually manageable. The cardiovascular effects, though, that's the real liability, isn't it?
That is the single biggest safety concern with TCAs, yes. Tachycardia, a fast heart rate, is common. That's caused partly by the anticholinergic effect blocking vagal tone and partly by potentiating the effects of noradrenaline on the heart.
Okay, what else?
Crucially, their blockade of the alpha-1 adrenergic receptor causes postural hypotension,
That's the dizziness when standing up quickly.
a sudden, potentially dangerous drop in blood pressure when standing up, which can lead to falls, especially in older patients. But most critically, the most dangerous effect is their direct impact on the heart's electrical conduction system.
Like antiarrhythmic drugs.
Ironically, yes. They have what's called a quinidine-like effect, similar to some class I antiarrhythmic drugs. They slow down conduction through the ventricles, which shows up on an ECG as widening of the QRS complex and prolongation of the QT interval. They also directly depress the contractility of the heart
That's a
muscle.
consequence.
This can lead to serious, potentially fatal ventricular arrhythmias, like torsides to points or ventricular fibrillation, even at doses that are considered therapeutic for depression. This proarrhythmic potential is dose-related, but can occur even without overdoses.
And this is the key reason why SSRIs, SNRIs, and the atypicals are considered fundamentally safer from a cardiac perspective.
Absolutely. It's a night and day difference in cardiac safety profile.
Okay, other common TCA side effects.
Sedation is very common due to that H1 receptor blockade. Weight gain is also frequently reported, which can be significant and affect compliance, though bupropion and most SSRIs are exceptions here, often being weight neutral or causing slight weight loss initially. Sweating, fine tremors.
Sexual dysfunction.
Yes, that's common too, similar to SSRIs in some ways, affecting libido, erection, or orgasm. And one other crucial risk. In patients who actually have underlying bipolar disorder but present during a depressive phase, TCAs, like other antidepressants, can precipitate a switch over into mania or hypomania. That's why careful diagnosis is so important.
Let's talk about acute poisoning. Given the population they treat, overdose risk is a major concern.
Acute TCA poisoning is a true medical emergency and unfortunately used to be a common method in suicide attempts due to their availability and lethality. The presentation is complex and dangerous.
It doesn't look like.
Initially, it often mimics severe atropine poisoning because of the strong anticholinergic effects. Excitement, agitation, delirium, confusion, dry flushed skin, dilated pupils, hyperthermia, tachycardia, urinary retention. This excitation phase is then often followed by convulsions, coma, profound respiratory depression, severe hypotension, low blood pressure, and the most life-threatening aspect, those severe ventricular arrhythmias we just discussed.
Treatment must be rapid and supportive.
Absolutely. Primarily supportive care, maintaining airway, breathing, circulation. Gastric lavage or activated charcoal might be considered early on if appropriate. Crucially, correcting metabolic acidosis, often with intravenous sodium bicarbonate infusion, can sometimes help reverse the cardiac conduction abnormalities. Controlling convulsions usually requires intravenous diazepam.
And the life-saving detail regarding arrhythmia treatment specifically. What must be avoided?
This is critical knowledge for anyone managing these overdoses. You absolutely must avoid Class IA antiarrhythmics like quinidine or procainamide, and Class IC antiarrhythmics like flecainide. You also generally avoid digoxin,
Why?
because these agents also depress cardiac conduction and myocardial contractility, and they will dangerously worsen the TCA-induced cardiotoxicity. They potentiate the problem.
So what can be used?
Treatment options are more limited. Intravenous bicarbonate is key. Sometimes magnesium might be used. For ventricular tachycardia, lidocaine, a class IB agent which has less effect on conduction, or sometimes propranolol, a beta blocker, might be carefully considered. But management is complex and often requires expert cardiology input.
What about drug interactions with TCAs?
Numerous and potentially serious. They potentiate the effects of sympathomimetic amines. So using adrenaline-containing local anesthetics in dentistry, for example, needs extreme caution or avoidance. They potentiate CNS depressants like alcohol, benzodiazepines, opioids. Combining TCAs with SSRIs can be dangerous because SSRIs can inhibit the liver enzymes CYP2D6 that metabolize TCAs, leading to toxic TCA levels.
And the MAOI combination?
Absolutely contraindicated. Combining TCAs and MAOIs can lead to severe hypertensive crises, hyperthermia, convulsions, delirium, sometimes called serotonin syndrome, although the mechanism might be more complex, involving both NA and 5-HT. It's a lethal combination.
So the first generation, the TCAs, defined by undeniable efficacy in many patients, but coupled with a very high risk profile, a narrow therapeutic window, and a low safety margin in overdose. This leads us directly and logically to the selective revolution.
Yeah, section 3. Exactly. The clinical community, patients too, realize that the frequent and often burdensome side effects of the TCAs, their inherent dangers, their low safety margin, the risk of fatality and overdose, it all necessitated a complete paradigm shift in drug development.
A search for drugs that were just as good, but safer.
That was the goal. The second generation of antidepressants, really starting in the 1980s, aimed for equivalent or potentially even higher efficacy, but with dramatically increased safety and tolerability.
And this revolution begins with the Selective Serotonin Reuptake Inhibitors, the SSRIs. How does their mechanism fundamentally change the safety landscape compared to TCAs?
The mechanism is elegantly simple, and that's the key. They selectively inhibit the membrane-associated serotonin transporter, or SERT. That's their primary intended target.
Selectively, meaning they don't hit those other receptors like the TCAs did?
Precisely. By selectively targeting only SERT, and crucially having little or no significant affinity for those problematic muscarinic cholinergic receptors, alpha-1 adrenergic receptors, or histaminergic H1 receptors, they essentially eliminate the most dangerous and bothersome side effects of the TCAs.
So no significant sedation, no dry mouth, constipation, no postural hypotension.
Generally, no, or at least much, much less significant than with TCAs. And most importantly, minimal, if any, direct interference with cardiac conduction. Their safety margin in overdose is dramatically higher. A patient taking a massive overdose of an SSRI is far, far less likely to die than someone taking a similar overdose of a TCA.
That safety profile is why they became first-line treatments so quickly.
Absolutely. It was a game changer for outpatient psychiatry.
So the overall safety profile improves dramatically, but the side effect profile doesn't disappear, it simply shifts. What are the common complaints that are unique to high serotonergic activity caused by SSRIs?
Right. You trade one set of side effects for another, generally milder, set. The most common initial effects are often gastrointestinal. Nausea is quite common, especially early on.
Why nausea?
It's thought to be due to stimulation of 5-HT3 receptors, possibly in the gut or the brain's chemoreceptor trigger zone. Thankfully, tolerance to the nausea often develops over the first week or two. Loose motions or diarrhea can also occur, likely due to blocking serotonin uptake in the gut, where serotonin plays a role in motility.
But the side effect that often impacts compliance the most.
That would undoubtedly be sexual dysfunction. This is a very common issue with SSRIs. It typically manifests as difficulty achieving orgasm, delayed ejaculation in men, or sometimes reduced libido in both sexes. It can be quite distressing and is a major reason people stop taking the medication.
Are there other common mild effects?
Yes. Things like nervousness or restlessness, sometimes insomnia, especially early on. Some people report headaches or anorexia, a loss of appetite, though weight gain can sometimes occur with long-term use in some individuals.
I see a note here about a somewhat surprising increase in bleeding risk. Why would boosting serotonin affect clotting?
It's an interesting mechanism. Platelets, which are essential for blood clotting, actually store and utilize serotonin. They take it up from the blood using the same SERT transporter that the SSRIs block.
Ah, so SSRIs prevent platelets from loading up on serotonin.
Exactly. By inhibiting SERT, SSRIs impair the platelets' ability to take up and store serotonin effectively. This seems to impair their normal function in aggregation, which is a key step in forming a blood clot.
And how does this show up clinically?
It translates into a statistically increased incidence of things like easy bruising ecchymosis or nosebleeds epistaxis. More seriously, there's evidence it can increase the risk of gastrointestinal bleeding, especially when SSRIs are combined with other drugs that irritate the stomach or impair clotting, like NSAIDs, nonsteroidal anti-inflammatory drugs.
Good to know. Now, a major area of concern for any clinician prescribing these is drug-drug interactions, particularly involving those liver enzymes, the cytochrome P450 system. Can you translate the technical acronyms like CYP2D6 and CYP3A4 into clinical reality for us?
Absolutely critical point. These CYP enzymes are the workhorses in the liver that metabolize the vast majority of drugs we take. Many SSRIs, especially fluoxetine and fluvoxamine, are potent inhibitors of specific CYP isoenzymes, particularly CYP2D6, but also others like CYP3A4 or CYP1A2 to varying degrees.
Inhibitors, meaning they stop the enzymes from working.
Effectively, yes. They prevent the enzymes from breaking down other drugs that happen to be metabolized by that same enzyme pathway.
And the clinical implication?
The clinical implication is that the SSRI can cause the plasma levels of the other co-administered drug to rise, potentially to dangerous or toxic levels. This is especially critical for drugs that have a narrow therapeutic index, where the gap between an effective dose and a toxic dose is small.
Like which drugs?
Classic examples include the older TCAs themselves. Combining an SSRI with a TCA can dangerously elevate the TCA level. Also, some antipsychotics like clozapine or risperidone, beta blockers, some antiarrhythmics, and the anticoagulant warfarin. It's absolutely essential to check for these potential interactions before co-prescribing an SSRI with other medications.
And this boosting of serotonin activity leads directly to the risk of the potentially fatal serotonin syndrome.
Yes. This is a hyperserotonergic state caused by excessive serotonin activity in the central nervous system. It's a medical emergency.
How does it present? What are the key signs?
It typically presents with a characteristic triad of symptoms. First, autonomic hyperactivity. Things like high fever, hyperthermia, sweating, flushing, tachycardia, possibly large fluctuations in blood pressure. Second, neuromuscular excitement, muscle rigidity, tremors, myoclonus, sudden muscle jerks, hyperreflexia, sometimes progressing to seizures. And third, altered mental status. Agitation, confusion, disorientation, sometimes delirium or coma.
And what precipitates it? What combinations are riskiest?
It's most famously precipitated when an SSRI is combined with an MAOI that's an absolute contraindication. But it can also occur if an SSRI is combined with virtually any other drug that significantly boosts serotonergic activity. This includes TCAs, especially clomipramine, SNRIs, triptans used for migraine, the opioid tramadol, pethidine, linezolid, an antibiotic with MAOI properties, lithium, St. John's wort. The list is quite long.
Which is why you need that washout period when switching.
Absolutely mandatory. You need a sufficient drug-free interval, often several weeks, especially when switching to or from an MAOI or a long-acting SSRI like fluoxetine, to allow the first drug to clear the system completely before starting the second.
Okay, let's look a bit more deeply at the specific SSRIs because they aren't all identical. Their different half-lives and metabolic pathways significantly impact clinical use, starting with fluoxetine Prozac, the classic agent.
Fluoxetine is really characterized by being the longest-acting drug in the class by far. Its own plasma half-life is around 2 days, which is already long, but its active metabolite, norfloxetine, persists for an incredibly long time. Its half-life is typically 7 to 10 days.
Wow, so it stays in the system for weeks after stopping.
Yes. This has pros and cons. The pro is that it's very forgiving if a patient misses a dose or two. Withdrawal symptoms are less likely because the levels decline so slowly. It's good for patients who might struggle with adherence.
And the con?
The con is that if a patient experiences a troublesome side effect, it takes a very long time, weeks, for the drug and its metabolite to wash out of the system after stopping it. Also, that long half-life necessitates an especially long washout period before starting potentially interacting drugs like MAOIs. Fluoxetine also tends to have a slightly more stimulant or activating effect initially compared to some other SSRIs, which can sometimes worsen anxiety or agitation in the first week or two. It's also the one approved down to age 7 in children for depression.
What about fluvoxamine?
Fluvoxamine has a shorter half-life, around 18 hours. It's notable for being particularly effective and often used specifically for obsessive-compulsive disorder, OCD, and sometimes generalized anxiety disorder, GAD. However, it tends to cause higher rates of gastrointestinal side effects compared to others, and because of its shorter half-life, discontinuation reactions or withdrawal symptoms can be more prominent if stopped abruptly. It's also a potent inhibitor of CYP1A2 and CYP2C19 enzymes, leading to significant interaction potential.
And sertraline.
Sertraline is very widely used, often considered a good all-rounder. Clinical data suggests fewer patients stop taking it due to side effects compared to some others. It also has a relatively lower likelihood of causing significant CYP-related drug interactions, particularly at lower doses, which is a plus. It's frequently used not just for depression, but also for various anxiety disorders, PTSD, and OCD.
Okay, then we have the citalopram family, Celexa and Lexapro.
Right. Citalopram itself is known for having a generally low propensity for drug interactions via the CYP system, which is advantageous. However, a significant cautionary note emerged some years ago. Reports linked higher doses of citalopram, above 40 mg a day or 20 mg a day in the elderly or those with liver issues, to dose-dependent QT interval prolongation on the ECG.
QT prolongation.
Yeah.
That's a risk factor for serious arrhythmias.
Yes, specifically Torsades de points. There were also reports of overdose deaths linked to this. As a result, there are now dose restrictions, and it should generally be avoided in patients with known QT prolongation, electrolyte imbalances, or those at high risk of suicide where overdose is a concern. Citalopram is sometimes preferred for premenstrual dysphoric disorder, PMDD.
Which is why citalopram, its active component, is often preferred now.
Exactly. Escitalopram is the active S enantiomer of citalopram. It's pharmacologically cleaner, effective at essentially half the dose of citalopram, the thing like 10 milligram citalopram, 20 milligram citalopram. And importantly, it does not appear to carry the same risk of significant QT prolongation based on current data. It's considered safer from that perspective and is one of the most popular and well-tolerated SSRIs currently used. It might also offer some mild relief from menopausal hot flashes.
And finally, there's duloxetine, which has a very specific targeted use case.
Yes, duloxetine is unique. It's an SSRI with very rapid absorption and elimination. It's promoted and approved specifically for the treatment of premature ejaculation in men.
Leveraging the common side effect of delayed orgasm.
Precisely. It's designed to be taken on demand, typically about 1 hour before anticipated sexual intercourse, to deliberately induce that delay in ejaculation for therapeutic benefit. A fascinating example of turning a side effect into a primary indication.
Okay, that covers the SSRIs. Moving to the next pillar of the selective revolution, the serotonin and noradrenaline reuptake inhibitors, the SNRIs. The idea here is to get that dual boost of serotonin and noradrenaline like the TCAs did, but without hitting all those other dirty receptors.
That's exactly the rationale. The SNRIs achieve dual inhibition of both the serotonin transporter, SIR2, and the norepinephrine transporter, NET. But crucially, they were designed to lack significant affinity for those problematic muscarinic, alpha-1 adrenergic, or histaminergic receptors that cause so many TCA side effects.
Venlafaxine Effexor is the main example here.
Venlafaxine was the first major SNRI. It's considered highly effective, and there are claims it might have a slightly faster onset of action than SSRIs, although that's debated. It's also sometimes thought to be effective in cases that haven't responded well to SSRIs, possibly due to the added noradrenergic component becoming significant at higher doses.
But it has its own cardiovascular caveat.
Yes. Unlike SSRIs, venlafaxine, especially at moderate to higher doses, has a clear tendency to raise blood pressure, both systolic and diastolic. This requires regular blood pressure monitoring, particularly when initiating the drug or increasing the dose. Other common side effects include nausea, sweating, anxiety, and dizziness. Abrupt discontinuation can also cause significant withdrawal symptoms.
Then we have duloxetine Cymbalta, a newer SNRI, whose clinical utility seems to extend far beyond standard mood disorders. This feels like a significant advance.
Duloxetine really is a game changer in many respects because of its distinct actions, possibly involving modulation of descending pain pathways in the spinal cord in addition to its central effects. While effective for depression and GAD, it has become a first-line treatment for several chronic, often debilitating physical pain conditions.
Which one specifically?
It's approved and widely used for diabetic peripheral neuropathic pain, for fibromyalgia, and for chronic musculoskeletal pain, like chronic low back pain or osteoarthritis pain. The dual NA5-HT action seems particularly beneficial for these neuropathic and chronic pain states where older drugs were less effective or had more side effects.
So it's working on the pain signaling itself.
That's the idea, modulating those descending inhibitory pain pathways. Furthermore, duloxetine has another unique approved indication: stress urinary incontinence in women.
How does it help with that?
It's thought to work peripherally by increasing the tone of the urethral sphincter muscle, likely via enhancing noradrenergic and serotonergic activity in the relevant spinal cord nuclei controlling the bladder outlet. It's a fascinating, highly specific application of a CNS drug for a peripheral problem. Duloxetine itself is mildly sedating compared to venlafaxine and can have some minor antimuscarinic effects like dry mouth, though much less than TCAs.
That level of specificity really underscores how far the field has moved from just general mood elevators toward targeted pharmacotherapy.
Absolutely. Understanding these nuances is key.
Now let's turn our attention to Section 4, the atypical arsenal. This seems like a crucial, but maybe more confusing, group of drugs. Heterogeneous is the word used, defined by unique, often complex mechanisms that move beyond simple reuptake inhibition into more sophisticated receptor modulation.
That's a good way to put it. The atypicals are really important because they offer different mechanisms of action which can be vital for treating patients who don't respond to SSRIs or SNRIs or who can't tolerate their side effects. They are a diverse bunch.
Okay, let's start with trazodone, Desirol. What's its mechanism?
Trazodone is interesting. It actually has only fairly modest serotonin reuptake blocking properties. Its primary activities seem to be antagonism at alpha-1 adrenergic receptors and, importantly, antagonism at serotonin 5-HT2A receptors. Its main metabolite, MCPP, is also a potent 5-HT2 blocker.
So blocking specific serotonin receptors rather than just boosting overall serotonin. How does that translate clinically?
It makes its profile very distinct. It is intensely sedative, largely due to H1 antagonism as well, but it's notably non-anticholinergic and relatively safe from a cardiovascular standpoint compared to TCAs. Because of the strong sedation, its main use nowadays is not really as a primary antidepressant, but more commonly as an add-on therapy or sole agent for patients whose depression is accompanied by severe insomnia. It's often given at lower doses at bedtime just for sleep.
But it carries a unique and quite serious risk warning.
Yes. That alpha-1 adrenergic blocking property introduces a rare but critical risk: priapism.
Priapism.
A prolonged, painful erection that is unrelated to sexual stimulation. It's a medical emergency because if not treated promptly, it can lead to permanent damage and impotence. Patients need to be explicitly warned about this possibility, however rare.
Okay. Next up, meancerin. This one genuinely seems to break the rules. The sources say it doesn't inhibit NA or 5-HT uptake at all.
That's correct. Meancerin is structurally related to TCAs, it's tetracyclic, but its mechanism is quite different. Its main action is blocking presynaptic alpha-2 autoreceptors and heteroreceptors.
Okay, alpha-2 receptors normally inhibit neurotransmitter release, right? They're the brakes.
Exactly. So by blocking these inhibitory alpha-2 receptors, meancerin effectively cuts the brake lines on noradrenaline release, leading to increased NA release and turnover. It might also enhance serotonin release indirectly via blocking alpha-2 heteroreceptors on serotonin neurons.
And its clinical profile.
Like trazodone, it's strongly sedative, H1 blockade. It lacks significant anticholinergic effects. However, its use has become quite restricted in many places due to rare but serious reports of blood dyscrasias, particularly agranulocytosis, a severe drop in white blood cells, and also potential liver dysfunction. It's not commonly used anymore.
Now, let's go deep on mirtazapine Remeron. This one is known as a NASA. Its mechanism sounds like a masterclass in targeted receptor engineering, aiming to optimize the useful serotonin signal while blocking the problematic ones.
Mirtazapine really is pharmacologically elegant. NASA stands for Noradrenergic and Specific Serotonergic Antidepressant. Its novelty is profound. Like meancerin, it blocks alpha-2 autoreceptors on NA neurons and alpha-2 heteroreceptors located on 5-HT neurons.
So dual blockade again. What does that achieve?
This dual blockade ensures a massive amplified release of both noradrenaline and serotonin simultaneously from their respective neurons. It really steps on the gas for both systems.
But the truly clever part seems to be how it then manages or directs that flood of serotonin specifically.
That's the specific serotonergic part of NASA. While boosting 5-HT release, mirtazapine simultaneously blocks two key postsynaptic serotonin receptors: the 5-HT2A2C receptors and the 5-HT3 receptors.
Why block those particular ones?
Because stimulation of 5-HT2 receptors is linked to anxiety, insomnia, and crucially, sexual dysfunction. Stimulation of 5-HT3 receptors is linked to nausea and GI upset. By blocking these bad receptors, mirtazapine effectively channels the increased serotonin preferentially towards activating the 5-HT1A receptors.
And 5-HT1A activation is thought to be the primary mediator of the antidepressant and anxiolytic effects of serotonin.
Precisely. So you get the enhanced serotonin release, but it's guided almost purely to the therapeutic target, 5-HT1A, while the pathways leading to common side effects, 5-HT2, 5-HT3, are blocked off.
That's quite sophisticated. What's its clinical profile like?
Clinically, mirtazapine is also a very potent H1 blocker, making it highly sedating. This makes it an excellent choice for depressed patients suffering from significant insomnia or agitation. Because it blocks 5-HT2, it notably does not typically cause the sexual dysfunction seen with SSRIs and SNRIs, which is a major advantage for some patients.
What are the downsides?
The main downsides are the sedation, which can be significant and frequent, sometimes substantial weight gain, possibly due to both H1 blockade and effects on appetite regulation. But for the right patient, especially with insomnia and concerns about sexual side effects, it's a very valuable agent.
Another essential atypical is bupropion Wellbutrin, or Zyban, known widely outside of depression for its use in smoking cessation. What defines its unique mechanism and risk profile?
Bupropion stands out because its primary mechanism involves inhibiting the reuptake of dopamine, DA, and, to a lesser extent, noradrenaline, NA. It has minimal direct effect on the serotonin system.
Dopamine and noradrenaline.
Yeah.
That sounds more stimulating than sedating.
Absolutely. It's generally considered an excitant or activating antidepressant rather than a sedative one. Its main active metabolite is actually structurally similar to amphetamine, contributing to this profile.
And it's used in smoking cessation.
Its primary non-depressive indication is as an aid to smoking cessation. It's thought to work by augmenting dopaminergic activity in the brain's reward pathways, potentially mimicking some effects of nicotine and reducing withdrawal symptoms and cravings. It provides quitting rates that are comparable to nicotine replacement therapy.
But its excitant nature comes with significant risks, particularly regarding seizures.
Yes, this is the most critical safety concern with bupropion. It carries the highest risk of inducing seizures among all currently marketed antidepressants. This risk is clearly dose-dependent, increasing significantly at doses above the recommended maximum, usually 450 mg a day for immediate release, lower for sustained extended release.
And certain patient groups are at much higher risk.
The risk is drastically elevated in patients with pre-existing seizure disorders, of course, but also in patients with eating disorders like anorexia or bulimia nervosa, possibly due to electrolyte disturbances, and in patients undergoing abrupt withdrawal from alcohol or benzodiazepines. Careful patient selection and adherence to dosing guidelines are paramount.
And given its stimulating properties, probably not ideal for anxiety.
Generally, no. Its excitant properties make it explicitly unsuitable for patients whose primary problem is a generalized anxiety disorder, panic disorder, or significant agitation, as it can often worsen these symptoms. It's more suited for depression characterized by low energy, apathy, and hypersomnia.
Finally, we need to briefly acknowledge amoxapine and then the really unusual uptake enhancers.
Right. Amoxapine is structurally a tetracyclic antidepressant, but it's unique because, in addition to inhibiting noradrenaline reuptake, it also significantly blocks D2 dopamine receptors, similar to older antipsychotics.
So it has mixed antidepressant and antipsychotic properties.
Exactly. This makes it potentially useful for treating psychotic depression, particularly cases unresponsive to other agents. However, that D2 blockade means it carries the risk of causing extrapyramidal side effects, EPS, like Parkinsonism, akathisia, or even tardive dyskinesia, just like traditional antipsychotics.
Yeah.
It's usually reserved for specific situations.
And then the odd ones out. Pneptine and ammoneptine, they increase serotonin uptake.
Yes, these are pharmacologically paradoxical. Pneptine, in particular, has been reported in some studies to enhance or increase the reuptake of serotonin, the opposite of SSRIs. The exact mechanism by which this leads to an antidepressant effect is still debated, perhaps involving effects on glutamate transmission or neuronal plasticity. Clinically, pneptine is described as neither sedative nor stimulant and is used for anxiodepressive states in some countries, though its abuse potential has become a concern recently. Ammoneptine also reportedly enhanced 5-HT uptake, but had significant anticholinergic and cardiovascular side effects, resembling a TCA, and is largely unavailable now.
Okay, that covers a huge amount of pharmacology. Now let's try to synthesize this knowledge into clinical strategy in Section V. looking at the specific uses of antidepressants beyond just general depression, and then tackling anti-anxiety strategies. Starting with major depression itself, where are the first-line SSRIs and SNRIs maybe not sufficient or need careful handling?
Great question. While SSRIs and SNRIs are definitely the first line for most patients due to their superior safety and tolerability profile compared to TCAs and MAOIs, we absolutely must keep reinforcing that time factor.
The 2 to 3 week delay minimum.
Minimum, sometimes 4 to 6 weeks or even longer for the full effect. This means for severely depressed patients, especially those with active, high suicide risk, no antidepressant acts fast enough on its own to guarantee safety in the immediate term.
So what's done in those acute high-risk situations?
In those cases, electroconvulsive therapy, ECT, remains a rapidly effective, often life-saving intervention. It can produce significant improvement within days to a couple of weeks, much faster than any medication. Hospitalization is usually required as well.
And what about treating depression specifically in the context of bipolar disorder? That requires a completely different approach to starting medication, doesn't it?
This is an absolutely critical point for mastery and patient safety. Antidepressants, regardless of the class SSRI, SNRI, TCA, whatever, when given alone to a patient with bipolar disorder during a depressive episode, carry a significant risk of triggering a switch into a manic or hypomanic episode.
So you can make things worse if you're not careful.
Much worse. Therefore, the standard practice, the rule, is that antidepressants should almost always be initiated in bipolar depression only after the patient has been successfully stabilized on a mood-stabilizing medication.
Like lithium or valproate.
Exactly. Drugs like lithium, valproate, sometimes lamotrigine, or certain atypical antipsychotics with mood-stabilizing properties. You need that mood stabilizer foundation in place first to mitigate the risk of antidepressant-induced switching. Sometimes antidepressants might be avoided altogether in bipolar depression or used only very cautiously for short periods.
Let's discuss some more specialized uses. Obsessive-compulsive disorder, OCD. It's notoriously difficult to treat.
Yes, OCD seems to require very specific and robust serotonergic modulation. The antidepressants that are most effective are those with potent serotonin reuptake inhibition.
So primarily the SSRIs.
Primarily the SSRIs, yes. Fluvoxamine, fluoxetine, sertraline, paroxetine are all approved and effective. Interestingly, the older TCA, clomipramine, which is a very potent serotonin reuptake inhibitor, though non-selective overall, is also highly effective for OCD. Sometimes considered even more so than SSRIs in difficult cases, despite its side effect burden.
And the treatment approach differs from depression.
Yes, typically OCD requires higher doses of these serotonergic agents than are usually needed for depression. And perhaps even more importantly, the therapeutic response takes much longer to manifest. You often need to treat for a full 2 to 3 months at an adequate dose before seeing significant benefit compared to the weeks typically needed for depression. Patience and persistence are key.
What about addressing that anxiety-depression axis overlap we talked about earlier? How do we manage chronic anxiety disorders long-term?
This is where the SSRIs and SNRIs have really revolutionized treatment for generalized anxiety disorder, GAD, panic disorder, social anxiety disorder, social phobia, and post-traumatic stress disorder, PTSD. The SSRIs and SNRIs are now firmly established as the first-line long-term pharmacological treatments of choice.
Even though they take time to work for anxiety, too.
Yes. Just like in depression, they exert a delayed but sustained therapeutic benefit. They don't just mask the anxiety symptoms acutely, they seem to help remodel the underlying neural circuits involved in fear and worry over time. They reduce the frequency and intensity of panic attacks, lessen generalized worry, improve social avoidance, and help process traumatic memories in PTSD.
But often, patients with severe anxiety need something faster initially. The fast-acting benzodiazepines still have a role there, right?
Absolutely. They are critical for managing the acute phase or severe exacerbations of anxiety or panic. A common and very effective strategy is to combine treatments initially. You might start an SSRI or SNRI for the long-term maintenance treatment, but because it takes weeks to work, you might also co-prescribe a short, time-limited course of a fast-acting benzodiazepine, like lorazepam or alprazolam, for the first few weeks.
To bridge the gap.
Exactly. To provide rapid relief from the acute anxiety or panic symptoms and bridge the gap until the slow-acting antidepressant takes therapeutic effect. Then, the benzodiazepine is carefully and gradually tapered off, leaving the patient on the long-term SSRI-SNRI monotherapy.
Speaking of specialized uses, let's quickly revisit neuropathic pain.
Right. While older TCAs, particularly amitriptyline, were historically used and do offer relief for neuropathic pain, likely via both NA and 5-HTFX, maybe sodium channel blockade too, they come with all the TCA side effects.
And today, the preferred agent is often.
Today, the SNRI duloxetine is arguably the preferred first-line antidepressant class drug for diabetic neuropathy and other forms of neuropathic pain, as well as fibromyalgia, due to its proven efficacy and much better tolerability profile compared to TCAs. Another SNRI, venlafaxine, also has evidence. Some TCAs, like nortriptyline, are still used too, often at lower doses than for depression.
Briefly, what about ADHD or smoking cessation?
For ADHD, while stimulants are first line, certain antidepressants are used as second or third line options, particularly if there are co-occurring conditions or issues with stimulants. TCAs like imipramine, nortriptyline, or desipramine have shown efficacy. Atomoxetine, which is technically a selective noradrenaline reuptake inhibitor, an NRI, not SNRI, is specifically approved for ADHD and offers a non-stimulant alternative. And as we mentioned, bupropion is specifically approved and widely used as an aid for smoking cessation.
Okay, great overview of antidepressant uses. Now let's pivot slightly to focus specifically on anxiety drugs, the anxiolytics. How are these defined differently from antidepressants?
Anxiolytics are primarily defined as mild CNS depressants, aimed specifically at controlling the symptoms of anxiety without significantly impairing normal mental or physical function at therapeutic doses. They differ from antipsychotics. They don't treat thought disorders, don't cause extrapyramidal effects. And unlike antidepressants, their primary effect is often rapid symptom relief, though tolerance and dependence can be issues. Many also have anticonvulsant and muscle relaxing properties.
And the primary, most well-known class here remains the benzodiazepines, or BZDs, Valium, Xanax, Ativan.
Yes, despite concerns about dependence, BZDs remain widely used due to their rapid efficacy, relative safety in overdose compared to older sedatives like barbiturates, and generally minor effects on other body systems at therapeutic doses.
How do they work? What's the core mechanism?
BZDs work by binding to a specific site on the GABA-A receptor complex in the brain. GABA is the primary inhibitory neurotransmitter. BZDs don't activate the receptor directly, but they enhance or facilitate the inhibitory effect of GABA when it binds to the receptor. They essentially make the brain's natural calming system work more efficiently, particularly in the limbic system, which is involved in emotion and anxiety.
Their selection often seems driven by how long they last in the body, their pharmacokinetics. Can you break down the kinetic implications? This seems crucial for choosing the right BZD for the right situation.
Absolutely critical. The main difference lies in how quickly they are metabolized and whether they produce active metabolites. This dramatically impacts their duration of action and suitability for different patients.
Okay, give us some examples, like diazepam, Valium, or chlordiazepoxide, Librium.
These are classic examples of long-acting benzodiazepines. They themselves have long half-lives, but more importantly, they are metabolized in the liver into multiple active metabolites, like desmethyldiazepam, which also have very long half-lives.
So the effect lingers for a long time, even after stopping the original drug.
Exactly. This results in a very prolonged duration of effect. This can be beneficial for conditions requiring stable, long-term coverage, like managing alcohol withdrawal or providing continuous anxiolysis. Diazepam, being rapidly absorbed, is also preferred for treating acute panic attacks or status epilepticus intravenously. However, the long half-life and metabolite accumulation increase the risk of daytime sedation, cognitive impairment, and falls, especially in the elderly.
In contrast, what about drugs like oxazepam, Serax, or lorazepam, Ativan?
These are examples of shorter-acting benzodiazepines. The key difference is their metabolism. They are metabolized primarily by a simple one-step process called glucuronide conjugation directly in the liver. Crucially, this process produces no active metabolites.
No active metabolites. So once the drug itself is gone, the effect is gone.
Pretty much, yes. They have shorter, effective half-lives. This makes them significantly safer and generally preferred for elderly patients or those with significant liver disease, as the risk of drug accumulation and prolonged sedation is much lower.
And lorazepam has a specific advantage for administration.
Yes, lorazepam is unique among the commonly used BZDs in that it is reliably absorbed when given intramuscularly, IM. This makes it very useful for managing acute agitation or severe anxiety in emergency settings where intravenous access might be difficult or delayed. Oxazepam is even shorter acting, sometimes used just for sleep.
What about alprazolam, Xanax, and clonazepam, Klonopin? They are known for high potency.
Yes, alprazolam and clonazepam are considered high-potency benzodiazepines. Alprazolam has a relatively short to intermediate duration of action. It's particularly noted for having some potential mild mood-elevating or antidepressant action, in addition to its potent anxiolytic and antipanic effects. This makes it appealing for patients with mixed anxiety and depression. However,
There's a downside.
it seems to carry a higher risk of producing significant dependence and marked withdrawal symptoms, some including seizures, upon abrupt discontinuation, possibly more so than other BZDs. Clonazepam also has high potency and a longer duration of action. It's highly effective for the urgent treatment of acute panic attacks and is often used as that initial bridge therapy we discussed while waiting for an SSRI to kick in for panic disorder. It's also used as an anticonvulsant.
Okay, BZDs are effective acutely, but the risks of sedation, tolerance, dependence, and withdrawal limit their long-term use. What if a patient needs a long-term anxiolytic but must avoid those BZD-related problems? This leads us to buspirone.
Puss. Buspirone is the key non-benzodiazepine alternative for chronic anxiety. Its profile is completely different.
Also, what's its mechanism?
Crucially, it does not interact with the BZD receptor site on the GABA complex. It doesn't facilitate GABA, it doesn't cause sedation, it has virtually no potential for dependence or abuse, and there are no significant withdrawal symptoms upon discontinuation. Patients don't develop tolerance to its effects.
So how does it work?
Its primary mechanism is thought to be acting as the selective partial agonist at presynaptic serotonin 5-HT1A receptors. By stimulating these inhibitory autoreceptors, it initially reduces serotonin release, but over time this leads to adaptive changes and ultimately modulates serotonergic activity in a way that relieves anxiety. It might also have some effects on dopamine D2 receptors.
Partial agonist, and it affects serotonin. That sounds like it might take time to work, like the antidepressants.
Exactly. That is the major clinical difference from BZDs. Buspirone's therapeutic effect develops slowly, typically requiring 2 to 3 weeks of continuous treatment before significant anxiolysis is apparent.
So no good for acute panic attacks or immediate relief.
Absolutely not. It's completely ineffective for acute anxiety relief. Its use is primarily for the management of chronic, persistent, mild to moderate generalized anxiety disorder, GAD, where the need for rapid, on-demand relief is not the main issue. It's a maintenance therapy, not an acute one. It also won't prevent BZD withdrawal symptoms if someone is switching.
What about other non-BZD options? Hydroxyzine, beta blockers.
Hydroxyzine is basically an older antihistamine, like Benadryl's cousin, with prominent H1 blocking properties. This makes it very sedating. It can be useful for anxiety where sedation is acceptable or even desired, perhaps for reactive anxiety or anxiety with marked autonomic symptoms like itching or hives. Beta blockers, like propranolol, have a very specific role.
They don't treat the anxiety itself, right?
Correct. Beta blockers do not affect the core psychological symptoms of anxiety, the worry, the fear, the apprehension. What they do is block the peripheral effects of adrenaline and noradrenaline on the body.
So they stop the physical symptoms.
Exactly. They effectively relieve the somatic or physical symptoms of anxiety. The pounding heart palpitations, the shaking or tremor, the sweating, maybe that feeling of butterflies or GI hurrying. They work by cutting that vicious cycle where physical symptoms fuel psychological anxiety and vice versa.
Which makes them good for specific situations.
They are particularly valuable for predictable performance anxiety or situational anxiety. Things like public speaking, musical performances, examination fear, stage fright. Taking propranolol an hour or so before the event can blunt those distracting physical symptoms without causing sedation or cognitive impairment like a BZD might. They aren't generally used for chronic GAD or panic disorder itself.
Okay, so synthesizing this into an overall mastery strategy for anxiety management, it really seems to rely heavily on managing expectations, especially regarding speed of onset versus long-term safety and efficacy.
That's the absolute key takeaway. For acute anxiety, severe panic attacks, or short-term situational stress, the benzodiazepines, like diazepam, lorazepam, alprazolam, clonazepam, remain the established drugs due to their rapid, reliable action. But they must be used judiciously, smallest effective dose for the shortest possible duration and always withdrawn gradually to minimize withdrawal issues.
And for chronic anxiety, long-term management.
For the long-term maintenance treatment of GAD, social anxiety, panic disorder, OCD, PTSD, the SSRIs and SNRIs, despite their delayed onset of action, weeks, are overwhelmingly the drugs of choice. They offer sustained benefit, treat the underlying condition, and critically, lack the dependence and tolerance liability of BZDs. Buspirone is a non-sedating, non-dependence-forming alternative specifically for chronic GD. Understanding that fundamental trade-off rapid relief with risk, BZDs, versus slow onset with sustained benefit and safety, SSRIs and buspirone, is the cornerstone of effective rational anxiety treatment.
That wraps up our incredibly detailed deep dive into this pharmacological landscape. We've journeyed from the first, often dangerous discoveries right through to the molecular engineering and targeted therapies of today. It's time for our final takeaways.
Okay, our mastery review really focuses on three core distinctions you need to grasp. First, the generational divide. You absolutely must be able to contrast the dirty action, the multi-receptor blockade, the high anticholinergic burden, and especially the catastrophic cardiac toxicity potential of the older MAOIs and TCAs.
With the much cleaner profile of the newer agents.
Exactly. Contrast that with the selective mechanism, the relatively clean side effect profile, and the significantly higher safety margin in overdose offered by the SSRIs and SNRIs. That safety differential drove the selective revolution and remains the single most critical practical insight.
Second takeaway.
The critical time factor. Always remember and be able to explain the therapeutic delay. It's not some random quirk, it's a reflection of the underlying biology. That 2 to 3 week minimum wait, often longer, is necessary.
Why again? Remind us.
It's the time needed for that initial monoaminergic surge to trigger the gradual desensitization of those inhibitory presynaptic autoreceptors, which then allows for sustained neurotransmission enhancement, which then likely promotes BDNF production, neurogenesis, and the slow adaptive structural repair in relevant brain circuits. It's biology in motion, and it takes time. And finally, the third key point, anxiety management strategy. Know the fundamental difference between treating the acute symptom versus treating the underlying source or vulnerability.
The BZDs versus the rest.
Precisely. Understand the crucial trade-off. The fast-acting, potent relief offered by benzodiazepines comes with the significant risks of sedation, tolerance, dependence, and withdrawal. Contrast that with the slow-acting but neuroplastically focused, safer long-term options like the SSRIs, SNRIs, and buspirone, which address the underlying disorder without the dependence liability. Choosing the right tool for the right time frame is essential.
It's become incredibly evident throughout this discussion that these agents are not just simple mood brighteners or chemical balancers. They are profound modulators of neuronal plasticity, growth factors, and brain adaptation.
Which leads us directly to our final provocative closing thought for you, the learner, to consider. If the fundamental antidepressant action, the thing that truly lifts pathological depression over time, requires not merely an immediate chemical tweak like blocking a pump, but rather these time-dependent biological adaptations, structural remodeling, and physical neurogenesis, possibly driven by enhanced BDNF production.
If it's about rebuilding brain circuits,
then what are the ultimate implications, ethical and biological, for using these powerful agents to treat chronic, non-pathological human discontent, or just generalized low mood? Especially considering their increasing off-label use, sometimes driven by patient requests simply to improve outlook on life and to feel good, in individuals who do not meet the full diagnostic criteria for a major depressive or anxiety disorder. What does it mean to medically facilitate brain adaptation in the absence of clear pathology? Something to think about.